Hi, my name is Tyler Kirby. I'm a gynecologic oncologist with West Coast Gynecologic Oncology in Clearwater and Tampa, Florida. Today we're going to be talking about endometrial cancer. Endometrial cancer is the most common gynecologic cancer in the United States, affecting over 60,000 women per year. The most common risk factors for endometrial cancer are obesity, followed by estrogen excess, such as polycystic ovarian syndrome. Also, tamoxifen use and other hereditary factors, such as Lynch syndrome, can contribute to endometrial cancer risk. The uterus is located at the top of the vagina, with the ovaries located to either side of the uterus. On a side view, the uterus can be seen with the bladder sitting in front and the rectum sitting behind the uterus. The endometrium is the lining of the uterus. Normally, estrogen stimulates this lining to grow thicker, while progesterone matures this lining to prepare for egg implantation. However, if there is no implantation, then progesterone levels drop and the lining is shed in the form of a menstrual cycle. If progesterone is absent, then the lining continues to thicken in an uncontrolled fashion, eventually leading to cancer. Stage 1 cancers are limited to the uterus, whereas Stage 2 cancers involve the cervix. A Stage 3 cancer would involve the lymph nodes, and Stage 4 would be any distant metastasis. Traditionally, most endometrial cancers were treated with a laparotomy, which is a large incision in the abdominal wall. These large incisions resulted in a prolonged postoperative recovery, requiring between 3 to 5 days in the hospital and at least 6 weeks of recovery time. In addition, complication rates are much higher with a laparotomy, as high as 30% for obese patients with hypertension, diabetes, or other risk factors. The arrival of the robotic surgery platform has allowed the performance of complex tasks that would normally have required a laparotomy to be done via laparoscopy. This has significantly reduced the recovery time and has allowed us to reduce the risk of complications to around 3 to 5%. After anesthetizing the abdominal wall, several incisions are made for placement of laparoscopic ports. The patient is then positioned in a steep head-down position to allow gravity to retract the bowel out of the operative field. The robotic arms are then brought into position between the patient's legs and attached to the previously placed ports. The camera and several cutting and coagulation instruments are then attached to the robot and advanced into the abdominal cavity. The surgeon then leaves the bedside and proceeds to the robotic console in the same room. The robotic camera actually has 2 cameras inside, with each image fed to the surgeon's separate eyes, resulting in a 3-dimensional view. The surgeon manipulates the robotic instruments via hand controls and foot pedals. The surgeon's movements are translated to movements of the robotic arms, with the option for 5-to-1 scaling, allowing for amazing precision and dexterity. The hysterectomy initially proceeds by incising the round ligaments. The ureters are then identified. The ovarian vessels are isolated away from the ureter and then divided. The uterine vessels are then skeletonized, which allows the ureter to fall laterally. The same is then repeated on the opposite side. The bladder is then dissected off of the front part of the uterus and cervix. An incision is then made in the anterior vagina over a cup that is part of the uterine manipulator. A similar incision is then made in the back of the vagina. The uterine vessels are then coagulated and cut. The vaginal angles are then cut as well. The uterus is then extracted through the vagina intact. If it is too large to fit out the vagina, it may be placed into a bag and removed through a small abdominal incision. The vaginal cuff is then closed with a delayed absorbable suture using absorbable clips to secure the suture. Lymphadenectomy for uterine cancer staging is important as this allows for the accurate detection of tumor spread and staging. PET-CT and other current imaging technologies are only about 75% sensitive, which means that of patients with metastatic spread, they would miss a quarter of these. Palpation or inspection of lymph nodes is not accurate. They must be removed and looked at microscopically. Removing these lymph nodes allows for accurate determination of stage for adjuvant therapy decisions. Without accurate staging, many patients receive unnecessary radiation and conversely are ineligible to receive much-needed chemotherapy. Lymphadenectomy involves the removal of lymph nodes from the pelvis and periaortic area that drain the uterus. Prior studies reported no increase in the immediate complications compared to hysterectomy without removing lymph nodes. However, there is a 5 to 10% risk of permanent lymphedema or swelling in the legs. This appears to depend on individual anatomical differences, the number of lymph nodes removed, as well as the presence of cancer in the lymph nodes or subsequent radiation therapy. Periaortic lymphadenectomy initially begins with the incision of the peritoneum overlying the inferior aorta and vena cava. The ureter is identified and retracted laterally. The aorta and iliac vessels are exposed. The lymph nodes are dissected off of the aorta with electrocautery. The lymph nodes are then dissected off of the vena cava as well. Care is taken to avoid injury to these critical vascular structures. Initially, the iliac vessels are exposed. The obturator nerve is identified and the lymph nodes dissected out of the obturator space. The lymph nodes are then dissected off of the iliac vessels as well. Once the lymph nodes are completely dissected off, these are placed into a bag and extracted. After a robotic hysterectomy, most patients are able to go home first thing the next morning. They're usually back to driving within 1 to 2 weeks, or whenever they're comfortable enough to slam on the brakes and not hurt themselves and are off of any narcotics. Normal activities, including work, may be resumed in 2 to 3 weeks. Of course, this will vary depending on the extent of the surgery as well as the physical activity of a patient's job. Pain is usually minimal after a robotic hysterectomy, and most patients are off of any narcotic pain medication within 2 to 3 days. Patients with uterine cancer having lymphadenectomy are at risk for blood clots after surgery. Therefore, they may be placed on an injectable blood thinner for 2 weeks, such as Lovenox or Arixtra. If this is the case, we usually will arrange for a home healthcare nurse to assist with any home injections. Most patients are seen 2 weeks postoperatively. It is at this time that we will go over any pathology results and discuss possible further treatment. This is also a time to check on a patient's incisions and see how they are recovering. Normal activities can usually be resumed at this time, although we caution patients not to engage in intercourse or any vaginal penetration for a minimum of 6 weeks. The vaginal cuff appears to be the slowest part of the surgery to heal, and if any stress is placed on the cuff suture line before it is completely healed, this may result in rupture of the vaginal cuff, requiring surgical repair. For most patients with stage 1 endometrial cancer, no further therapy is required. Survival for these patients is excellent, with over 90% of patients alive and disease-free at 5 years. We do normally perform a clinical exam every 3 to 6 months for 5 years as surveillance. For stage 2 patients, those with cervical involvement, we usually recommend either pelvic and/or vaginal radiation. We also will occasionally recommend chemotherapy, especially for more high-risk cell types. This usually will not be initiated until at least 6 weeks after surgery. For patients with metastatic cancer to the lymph nodes or other places, we normally recommend a combination of chemotherapy and radiation therapy. This usually involves 3 cycles of chemotherapy followed by 6 weeks of radiation therapy, followed by 3 additional cycles of chemotherapy, all of which is given in the IV. 5-year survival for advanced uterine cancer depends on the extent of disease, but usually is in the 60% range. There are some high-risk cell types that we would consider treating with chemotherapy even for stage 1. These include cell types such as papillary serous, clear cell, or grade 3 endometrioid tumors. Again, it's important to remember that everyone's cancer and subsequent treatment strategies are individualized. Thank you for joining me today.